GLP-1 agonist, that is what is the topic for me, for this lady who is 90 kilogram and already on SGLT-2, metformin, Acarbose and insulin. She's a post CABG, her weight is 90 kg, so, and she has eGFR, moderate CKD, and she is dyspneic with a diastolic dysfunction. So GLP-1 analog is very poorly understood, especially as a cardiologist, we do not understand it. It's difficult to understand because the name is GLP-1 agonist. It is like a glucagon-like peptide, so I thought it works like glucagon. But when I read it is a glucagon insulin secretor, but it is glucanostatic, so it inhibits actually glucagon. The name comes because it comes from the same gene by pre-processing where the glucagon molecule comes. So first, the name itself is a twister. Second, this is an anti-diabetic which all guidelines says it's a first line anti-diabetic drug. The biggest concern was it was injectable. Now some specific attribute of these drugs is the only anti-diabetic which secretes the insulin, but it is glucose dependent manner, like gliptins, which is another, because they are same group, incretin like molecule. Second is the only anti-diabetic which works on cerebral nervous system because it's going to cross blood-brain barrier, reduce appetite. Only anti-diabetic which works as GI because it is reduce the stomach motility. It's an only anti-diabetic which strongly inhibits glucagon, as I was telling, and it only anti-diabetic which has a specific interference with leptin resistance and has a specific role in adiposity and weight, where our concern in these patients are. Now, why we do not understand? So, the anti-diabetic, both we can say liraglutide and semaglutide, they first in lower doses they are anti-diabetic, but when you go on higher doses, they become weight reducing drugs, and when they are weight reducing drug, they reduce weight even in a non-diabetic. They, like a SGLT-2 inhibitor now are in non-diabetic, GLP-1 analog also can be used as a weight reducing drug. But the confusion comes because the drug doesn't, that weight reducing dose are not available in India, and company keeps different name. For example, liraglutide we all know is a Victoza, but the higher dose, which is weight reducing dose, is sold as Saxenda in USA. So it's the same liraglutide, but it becomes confusing because it has two names. Same happens with semaglutide. Now semaglutide is a more potent GLP-1 analog, which is an injectable. Now we have oral formulation available. Now in a lower or anti-diabetic dose, they call it Ozempic, but when they write the anti-obesity drug at the 3 milligram doses, they name it as a Wegovy. So recently, the Elon Musk tweeted, "I lost 12 kg by using Wegovy." So it is same semaglutide, but now it is available also in, and unfortunately, the higher doses are not available. We do not know the story of injectable semaglutide because it's never launched in India. But if you do not understand injectable semaglutide, it is difficult to understand oral semaglutide. So injectable semaglutide has been approved first as an anti-diabetic, then it has a CVOT which shows that it is reducing MACE events, and then 2021 it is a specific anti-obesity drug. As compared to liraglutide, semaglutide is more potent. There is a more weight reduction, more HbA1c reduction. So liraglutide reduces weight by 6 to 8%. Semaglutide will go 10 to 15%. And luckily, what we have is a oral semaglutide, which is most potent GLP-1 analog. So I think with this background, what is patient priority here? Here we want to achieve glycemic target HbA1c 8.2. We want to do better. We want weight management. Here the height is not there, but 90 kg lady, even if it is 5'6", 5'5", I believe the BMI would be more than 30. Now progression of CKD, definitely she has a CKD. We want to restore. We already, there is a SGLT-2 inhibitor is already there, which will prevent progression. But on top of SGLT-2 inhibitor, GLP-1 analog also can give her an additional nephroprotection. And we definitely want to prevent an adverse cardiac event. Though she is a post bypass, atherosclerosis is probably taken care of, but these drugs would produce the stroke. ASCVD are prone to stroke also, nephroprotection. And most important, as a heart failure or cardiologist, we are expecting this might be a high risk for atrial fibrillation and HFpEF. And these are the management issues which we believe that is all 4 priority can be taken by GLP-1 analog. And this is a slide where you have seen all gliptin lectures. You listen that the incretin effect, when we eat sugar and we inject sugar, the insulin rise from oral route is more, because oral will stimulate the L cells to give GLP-1 increase, and that is called as an incretin effect. And as you go on high level of GLP-1 analog, as you can see the progressive GLP-1 activity, you have more and more side effects. In physiological doses, when you get by DPP-4 inhibitor, you have increase in insulin secretion, reducing glucagon. But as why I was explaining is higher doses, they have appetite, food, caloric intake, weight loss, gastric empty, and even a cardiovascular efficiency. So GLP-1 analog has demonstrated a good efficiency. So average, if you speak glycemic efficiency, these are n number, all different what you say, these GLP-1 analog, which is liraglutide, semaglutide, dulaglutide, and all of them you can see has a very significant reduction in the HbA1c, and most potent, the blue bar, is the semaglutide. Then apart from that, as I was started my presentation, these are weight loss medicine. So when last year in June in USA, injectable semaglutide in the higher doses by name of Wegovy 3 mg was approved, and the indication was anybody with BMI more than 27 with 1 CV risk factor is a candidate, and anybody who is more than 30 BMI, irrespective, even if these are candidates. So can you guess what the population comes under the indication of the drug? US population. Any guess? 30%, 50%, 70%? 70% of population come under the indication of BMI more than 27 plus 1 CV risk factor, and not the company marketed, nobody marketed, but the drug which was produced for 6 months, 8 months was over in 2 months, and there is lack of stocks of injectable semaglutide in USA, and the YouTuber and all, they patient to patient publicity was so fast that the company didn't have the drug. So strong weight reduction. But yes, what available with us in India is liraglutide, which is in the anti-diabetic dose. It's not a weight loss dose is available, the Victoza. And what we have oral semaglutide, which is 3, 7 and 14 milligram. It is again the Ozempic dose. The pharmacology, it is not that, the weight reducing. So currently it's only an anti-diabetic drug. But even in what anti-diabetic doses, we do see a very good reduction in weight. So oral semaglutide reduces, so apart from injectable, now these are the various trials of oral semaglutide. So when you give oral semaglutide, the drug level is similar to injectable in the what we will say Ozempic dose or the anti-diabetic dose. And these anti-diabetic dose, these are various studies, and as compared to all other drugs, you can see Pioneer 2 with AMPA, Pioneer 3 with CETA, Lira, even when you compare to the liraglutide, which is a strongest, one of the good GLP-1 analog, oral semaglutide also stands, and this is similar to what injectable does. So upper one is what we say is HbA1c or glycemic efficiency, and lower one is a weight reduction. So what we can say, like an injectable brother, the oral drug also reduces HbA1c by 1.5% and weight by approximate 5 kg. Definitely it is much more stronger to semaglutide, both in HbA1c reduction as well as weight loss. And a recent US FDA labeled was that Ribelsus or GLP-1 is now the first drug in adjunct to exercise and glycemic. So till now, actually for me, when leader trial came, we started using liraglutide to reduce cardiovascular events, and it was a very good experience. So what I say, that semaglutide, even in guidelines, injectable semaglutide, if you see science, injectable GLP-1 analog are first line drug, but because they are injectable, they were not that projected. But you can see now the moment oral drug is come, it has been now an adjuvant to diet, and this is a result, because it's so, if you see science, it was always, I'll say, first line drug, and people say that oral semaglutide is new. I'll say it's not new drug, it is a old wine in a new bottle, because injectable semaglutide already has been seen. We have seen all the story from a weight loss drug to CVOT efficiency till anti-obesity drug. So US FDA has now given it as an initial therapy. Now our patient who is a CKD patient, we all know majority of anti-diabetics uses is a problem. Even SGLT-2, which are nephroprotective, cut off GFR by in the kidney guidelines is 30, but now after we have seen the emperor reduce till even GFR of 20 we have used. Here GLP-1 analog can be used till lower GFR. The 15 GFR I think is a liraglutide cutoff, and Indian label of oral Ribelsus or oral semaglutide doesn't have any dose adjustment. for even till the end stage renal disease. Now, even if it's a diabetic patient has CKD, you do get the similar glycemic efficiency and weight loss, which I think not surprised that is you have a similar efficiency of the drug. But what we see, if you go with semaglutide pooled analysis in diabetic patients with CKD, what is pooled analysis? It's a combined analysis of injectable sema as well as oral sema, and what you see as there is a significant reduction in fall in GFR. So what you can see on the lower is the fall in GFR. This blue one with semaglutide, this is less fall in GFR as compared to the routine anti-diabetic. So semaglutide versus placebo, when semaglutide is used as a top, as an injectable oral pool analysis in all form of renal failure, moderate, mild or moderate CKD, you do find a better or reduction in decline in kidney function, and definitely this mechanism is additive and different from SGLT-2 inhibitor. Now GLP-1 analog has definitely reduced the MACE event. You have liraglutide, dulaglutide as well as sustain 6, which is injectable semaglutide, and you see a reduction in MACE event 26%, and you all have heard it is a predominant ASCVD use GLP-1 analog, predominant heart failure and CKD use SGLT-2 inhibitor, but our majority of patients have everything, all problems will come in a given patient, and majority of patients are probably candidate of both of them. And this is very interesting the observation with GLP-1 analog and meta-analysis from leader 6 of lira, sustain 6 of injectable sema and oral sema pioneer 6, a 32% reduction in the stroke events. Again, MACE events, we know that GLP-1 analog has a significant reduction in MACE event. A small MACE event is reduction SGLT-2 inhibitor also, but gliptins are neutral, there is no MACE reduction, and this is what is reflected in all guidelines, which obviously all of you know. Whenever there is a prior ASCVD, GLP-1 analog is the drug of choice. But what more beyond that in cardiology, when you have an obesity, this is a more interesting CVD. This has a connection, and 80% of our patients who are HFpEF, they are basically obese. So HFpEF, most important thing is overweight, and even obesity leads to arrhythmia, atrial fibrillation as well as ventricular tachycardia, because obesity related inflammation, epicardial fat in obese people leads to myocardial as well as atrial fibrosis. And HFpEF is one of the very common finding in type 2 diabetic, and as your BMI increases, there is beyond 25, if you see on the right side HFpEF, the incidence will correlate very linearly with the body mass index, is contrast to HFrEF. And we are going to get specific trials of obesity related HFpEF and use of GLP-1 analog. So obesity, definitely epicardial fat, and our patient is 66-year-old, is definitely is a high risk for development of atrial fibrillation because of her high BMI and diabetic. Weight loss and cardiac rehab, these are the two most proven therapy cardiac which improves the prognosis of HFpEF. So obesity definitely matters in cardiology because it is modifiable. So the effect of semaglutide on CV risk factor, it includes glucose metabolism, reduces body weight, reduces MACE, inflammation, lipid profile and blood pressure, and anti-atherosclerotic agent. So this patient will give proposal of GLP-1 analog, whether they want injectable, oral, it's up to the after the discussion with this patient. Now last, before I close my point, is one of the biggest benefit which I have seen in my patient, because now this patient actually is taking insulin. So these are a good patient, those who are taking multiple doses of insulin, they accept injectable therapy, and when we started using liraglutide, we have seen 50, 70 and even 100 unit reduction in insulin, and that is not too long, in a period of 3 to 6 months. And then when I went to, so it's a very large insulin sparing drug, and patients who were on say 20 basal, 14 of prandial insulin are on 15 to 16 unit insulin. So one of my maximum reduction in 4 months, I have seen patient of 180 units of insulin per day with 0.6. I increased to lira to 1.2, but came back to 1.6, and now he is on only 22 to 24 of basal insulin. So this, what I have seen, is a very large reduction. Literature says an average 50 unit insulin sparing. So moment the insulin requirement goes down, we will not see this weight 5 kg, we will see 10 kg, 20 kg, because insulin itself will contributes a lot to the weight of these patients. And I think with that I complete my presentation. Thank you.
Thank you for kind words. Thank you, Kamal, once again for. But I believe it's not debate because I'm not debating against Parveen that GLP-1 versus DPP-4 because I agree all the point that GLP-1 is the molecule which we should give to the patient with established cardiovascular disease. It is the molecule for weight reduction. So it's not direct debate, but just trying that those patients who are already on SGLT-2 inhibitor, elderly patient, maybe a more safe molecule which we can use. And we all know the benefits of the GLP-1, but how many of us are really using in our clinical practice and can use it because of the cost, because of injectable, and many more effect or side effects of the molecule too. The management on top of SGLT-2 inhibitor, should I tell it favors DPP-4? Yes. Now today, if I say that it's had become almost like first choice of after the metformin, either you put the patient on metformin and DPP-4, or you put the patient on who is already on metformin and SGLT-2. I think second choice will be definitely DPP-4, just to make that patient is using a very safe molecule. And if you are putting the patients on DPP-4, you need not to worry that patient is going to call you for any side effect. This patient is definitely overweight, obese, which I fully agree with that. eGFR is 45.7, and here one very important point is she is above the age of 65. That's an important point. And HbA1c of 8.2 with a fasting of 208 and 282. So first, as a diabetologist, I am not comfortable with the patient who is already on a glargine, SGLT-2 and alpha glucosidase inhibitor. I could not understand why diabetologist is doing. He is not up titrating the dose of insulin itself. If you have already started the patient on a glargine, let us try to target fasting sugar around 100 and 110. And why not to increase the dose of alpha glucosidase inhibitor also to achieve a post-meal glucose also less than 180, and probably this patient will achieve a target control even by just putting the metformin, alpha glucosidase inhibitor, SGLT-2, which is pre-oral anti-diabetic. Metformin definitely in reduced dose because the patient is CKD, and if I am putting the patient on a glargine, I will achieve the HbA1c of this patient less than 7 or around 7 without getting hypoglycemia with eGFR. So that's first thing which I will say, and with this case, I will first go with that. Whether I should add DPP-4 or not, that's the second part of it. We all know that use of glucose lowering medication in the management of type 2 diabetes. I agree again with the Parveen that patient with established cardiovascular disease or with CKD, the choice will be always with SGLT-2, with the GLP-1. But those who are not tolerating GLP-1 or to whom we are not writing or we are not in position to write them, then probably DPP-4 is a choice, but definitely those DPP-4 which have a established cardiovascular safety data. So like a linagliptin or a sitagliptin may be a choice of drug for those patients to whom we are not writing the GLP-1. Considering the medical history, yes, after the GLP-1, the choice will be again with the DPP-4 in addition to SGLT-2 and metformin and alpha glucosidase inhibitor, which is written here, particularly for controlling the post-meal glucose level to get control. Even ADA is not talking about the alpha glucosidase inhibitor, but we Indians use it very high because of our large amount of carbs in our diet, and that's the reason for them to have a post-meal glucose level which is very, very uncontrolled for that. So treatment is definitely to keep the patient asymptomatic. Now a patient with a eGFR of 45 or less than 46 or around that, our idea to keep this patient is a keeping asymptomatic, free of acute metabolic complication, to prevent development and progression of further diabetes complication, to preserve the cognitive function and physical activity, and to ensure an adequate quality of life, and to avoid the drug reaction too. So factors which I have to consider. Now, if you see the RSSDI guideline, we normally consider there are 7-8 factors which starts with A. A is the age of the patient. B is the BMI. That's higher the BMI, definitely you would like to use the molecule which will reduce the weight more. C is the CKD status. D is the duration of diabetes. E is the established cardiovascular disease. F is the financing position. That's very, very important, as Parveen is coming from Mumbai and must be seeing a lot of patients who are very rich and they can afford not only the semaglutide oral, but he can ask them to get the semaglutide injectable also. That's possible, but it may not be possible for each and every Indian patient. So that's what the F. The G is the glucose control, and whatever the molecule which you are using, first you try to up titrate the dose of those molecules also to achieve a good control, and then H is the hypoglycemia risk. So risk of hypoglycemia is also very important. A elderly male, a 66-year-old female having a eGFR which is less, probably if I will put here on any other molecule which may lead to hypoglycemia. I am a bit worried for that. And for that reason, I may be adding the DPP4 against. I am not going against the GLP-1. Still, I will put, as far as scientific evidence is concerned, I will also go with the GLP-1. But if patient is not affording, DPP4 could be a choice of therapy. Elderly, I will not call at the age of 66. If I will say that 66 is the elderly, some of them will kill me. So I'm not going to tell that 66 is a elderly. But type 2 diabetes, managing type 2 diabetes in a elderly population, definitely we have to worry for hypoglycemia, and that should not happen. The glycemic target may not be 7, but 7.5, 6.5 to 7.5. I always tell that it's a good on target control. You may not get less than that, and not by any condition patient should go in hypoglycemia. So in this particular patient, definitely patient is with established cardiovascular disease or a elevated cardiovascular disease. So SGLT-2 and GLP-1 will definitely go for that. ADA consensus for DPP4, it's a better glycemic durability compared to stepwise approach. For elderly and frail patient, what they are saying, DPP4 is a safe and easy to use option. And treatment recommendation for patient with higher cardiovascular risk, it is the stable DPP4, the brain, it acts at the to decrease some weight reduction also, and it helps at all the, if you see the multiple pathophysiological factors which are responsible for type 2 diabetes. If you add DPP4, SGLT2 and metformin, probably you are taking care of almost all the pathophysiological factors which are responsible for type 2 diabetes to have a hyperglycemia. So I may use DPP4 in this patient for a safety point of view, but definitely before that, as I told you, I will increase the dose of glargine, I will increase the dose of full dose of AGI, and I will definitely see that patient's dietary control is there and patient achieve a good glycemic control with that also. The cardiovascular outcome trial with DPP4 inhibitor, we know that with sexagliptin and with alogliptin, there was a signal of increase in hospitalization for heart failure. But that was not there with sitagliptin, which is now available in our country at a price which is 10 rupees. I mean, it's so cheap that anyone can afford to use it, and now we are using it also for large number of patients. And with the side effect profile of gliptin, if you see, it's very, very less. Hardly 3 to 4% of your patients will come and will have some complaint related to the drug interaction or drug side effects, while 97% of the patients to whom we are giving them a gliptin, patient will not come back or will not call, at least for the side effect point of view. So that's the safety profile of this, but definitely we may not go with the sexa or alogliptin, even they are also available. But at present, I will be more happy to use the sita and linagliptin, and sita particularly because the cost of sitagliptin in our country is very, very less, and that we can afford for each and every patient. This is the average A1C. Now, if I again compare with GLP-1 versus this sitagliptin, the average A1C is definitely less. But as I told you, the patient was not optimized the therapy by just by putting a 208 fasting blood sugar, giving them GLP-1. Will you able to decrease the 208 to 100? No, you have to increase the dose of glargine. So my point is, first I will definitely uptitrate the dose of existing therapy, and still if it not be controlled, my choice may be gliptin because it also decreases A1C roughly between 0.5 to 8. And these are the one of the paper which has been published from India also in a combination of using SGLT2 and DPP4. Now, why I will use DPP4? This could be the second reason, because we have now fixed dose combination available with SGLT2 and metformin. And if I want, even a low dose of metformin can be also added in the same group. So that is one of the advantage. A 66-year-old female, if you give her all multiple different type of medication, like using a oral semaglutide and asking her to get up early in the morning at 6 o'clock with 120 ml to drink, to take that medication, and then to remain for 1 hour not to take anything. And if she is a patient of a thyroid, probably she has to, after getting up, first she has to take the Ribelsus, then again after 1 hour she has to take the thyroid medication, and then again she has to wait for another 1 hour to have a cup of tea. So that could be again cumbersome for a 66-year-old female. So now with the combination therapy, particularly when this particular type of patients, I may use sita, metformin and SGLT2 in a one tablet, and maybe Acarbose which she is taking, maybe from 25 I will make 50 milligram 3 times daily, and still I can achieve a tight glycemic control. And this is the paper where we had used that SGLT2 and DPP4 in a Indian patients in a fixed dose combination, how effective it is. And based on CV risk and including heart failure, definitely with a patient with a very heart failure, still we know that there is a black box warning for DPP-4 inhibitor, but they say that the molecules which can be used more of a cardiac safe, like particularly linagliptin and sitagliptin, can be used, but not with established cardiovascular. I mean, with the heart failure, I may be a bit worried again, even with the sitagliptin also. But for CKD, definitely. For CKD, sitagliptin can be reduced at the reduced dose, and the linagliptin can be given even without any dose modification. Also, these are the also molecules DPP-4, SGLT-2, along with metformin. There is a significant weight loss, and now with alpha glucosidase inhibitor also had shown there is a weight reduction. So yes, weight is a concern for this patient. I may not go with the semaglutide, which may reduce the weight of my patient by 15 kg, but even 5% weight reduction will also improve a lot of metabolic profile for this particular patient, and that is enough for her to have a lot of benefit of weight reduction too. The strategy for these patients to start with metformin, DPP-4 and SGLT-2 and AGI whenever we want to use. So age is a very important. I would like to use one of the most safe drug with fixed dose combination. Comorbid condition, as I understand, CBD, heart failure, CKD, no harm, because I am going to use a molecule which is safe for heart. Benefit risk ratio, definitely it is positive because of the cost effectiveness also, and it has got a sound clinical experience. All of us have used gliptin in last 15 years and we all are happy to use it. No risk of increasing hypoglycemia. And one very important point again, which I am putting here, that the cost, which is very, very important for Indian patient, and many of our patients, they are ideal candidate to start with them on a semaglutide or on liraglutide, but because of the cost, we just can't use for these patients. So my take-home message is individualized treatment strategy and targets for a elderly people with diabetes are now recommended by international guideline in order to achieve optimum risk to benefit ratio. Hypoglycemia, which is the most common and serious side effect in these patients, is of particular concern because it often occurs unexpectedly. The risk to benefit ratio of DPP-4 inhibitors may provide a valid treatment alternative in older patients with type 2 diabetes. DPP-4 inhibitors ensure high rate of adequate glycemic control, are associated with low risk of hypoglycemia, appear to have a neutral effect on body weight, and can potentially improve the quality of life. If necessary, a dose adjustment, which is required when the eGFR is decreasing, can ensure safe use even in the presence of advanced kidney failure. So this will be the only molecule probably which I may give the patient, and then I can tell that even your eGFR goes from 45 to 30 and 20 or even 10, you can still continue to use the linagliptin without any dose modification. With this, I once again thank you, Dr. Kamal and Cardiocon Organizing Committee, for giving me an opportunity. Thank you, sir.
Thank you, Navneet. It's always a pleasure to be around you. Banshi, colleagues, Dr. Kamal Sharma. I'm sort of disadvantaged because I've been pitted against two molecules that are established and importantly have a lot of clinical data. But if you're a person who invests in stocks, you invest in potential and not in just performance. I know that Banshi bought Titan about 20 years ago, and that's why, he's carefree today. So I think what we need to do is to talk about the potential of how we go into the next generation of therapies for diabetes and heart failure and heart disease, right? So since this is a cardiology meeting, I thought I would talk about the heart and how diabetes works. So the mitochondria this is the bioenergetics of the heart. In health, I don't know how many of you remember your Guyton days. Life is ATP to ADP and back. That's it. That's all life does. What we do is we produce about 65 kilograms of ATP per day and we consume it. Now, 8% of the ATP, and remember that the heart is only 1 to 2% of the body weight. 8% of the ATP is consumed by the heart. It has the highest mitochondrial content of any tissue, right? So there's an energy demand to the heart, and this is contributed by synthesis, transport, phosphorylation. Heart rate consumes energy, right? Relaxation and contraction consumes energy. This is supplied by two. One is glycolysis and something called oxphos. What is interesting to remember is while glucose is one of the most preferred fuels for the brain, the heart gets all its fuel by lipid oxidation. And I'll talk to you about it because that's where the problem also lies. Right? So if you look at the heart muscle, a majority of the muscle has mitochondria in it. And one of the important parts is something that we learned in medical school and most of us slept through it, is the respiratory chain. I'll talk about it again later. But what happens is there are two sets of fuels that come into the respiratory chain. One is from the tricyclic carboxylic acid cycle, which is, and this is glucose, and from acetoacetate, which is the fatty acids. In the respiratory cycle, hydrogen ion is exported into the inner membrane, and at some point of time it creates a gradient, and some of the hydrogen ion leaks back. This is called the uncoupled protein response, and this converts ATP to ADP. And this production of ATP is responsible in the pancreas for production of insulin, and in the heart for calcium cycling. In fact, one of the most important parts of what happens in the heart is calcium cycling. So the mitochondria deals with calcium cycling, and it's this calcium that comes into the cytosol that drives contractility, right? The third part is the production of some amount of superoxide dismutase and free radicals, which are all right normally, but if they accumulate, they create problems. I won't deal with this in detail, but just remember this is what is happening in the mitochondria. The mitochondria are so important that they have their own cycle. And what happens is they are able to recycle. Some of them, they fuse, they undergo fission. But what happens is the bad mitochondria are quickly destroyed and new good mitochondria are created. This is what is happening in the heart. And that is why your heart does not have to stop. That is why it keeps pumping. And that is why it's doing what it does. Right? But what happens in diabetes? What happens in heart failure is there is profound mitochondrial dysfunction, and that is what is causing your heart failure. What you're seeing as a sympathetic nervous system overactivity, what you're seeing as other things are the consequence of heart failure and the body's response to heart failure. But what is at the root of cardiomyopathy, cardiovascular dysfunction, perfusion re-injury? All of these are mitochondrial dysfunction. So here is the mitochondria, here is the myofiber, and can you see what happens? That during a normally ATP is present, the contraction and relaxation are very good. When ATP production comes down or ATP production is inefficient, both of these are not doing well, you get heart failure. So far, we've heard from everyone today about the response of the body to this problem. But the idea is in future, we will start addressing what is the actual problem, which is the mitochondrial bioenergetics. So for example, normally what happens is, I talked about the respiratory chain, the hydrogen ion is pumped into the inner membrane, and then some of it leaks back. But what happens when fuels accumulate, when we eat too much, when there is failure, the ions come back in a much greater amount, scavenger molecules are present, superoxide dismutase doesn't work, free radicals take place, the mitochondria dysfunctions, and therefore contractility comes down. This is what is happening there. So what is happening here? Let us go back to this picture. In heart failure, normally in mitochondrial dysfunction occurs, increased ROS, decreased electron chain transport, decreased calcium input. There is redox buffering. What does this lead to? HFpEF and HFrEF, right? So we think about HFpEF and HFrEF as a cause, but it's actually a consequence. So diabetes does even more. In diabetes, there's a mixture of fuels. Normally in the day, glucose is the fuel. In the night, fatty acids are the fuel. But in diabetes, we are eating too much. Both fuels are available. And what happens in the heart is, normally, the heart just takes fatty acids to a large extent. But when there is heart failure, when there is an ischemic event, the heart actually starting to use glucose. It starts using glycolytic pathways. And that actually is more efficient. But what really happens is, the fat intake into the heart does not come down. The heart continues to take the fat in, and these accumulate in the mitochondria. And the mitochondria undergoes dysfunction. I'm simplifying a lot of things here, but please understand what is happening here. So in cardiac disease, there are different things that can happen in the heart and the mitochondria. So one of this is that the fusion and fission that I talked about could be wrong. Mitophagy can go wrong. Calcium transport can go wrong. But at the base of all of this, the electron transport chain is the problem. This leads to cardiomyopathies, myocardial ischemia, and reperfusion. Until this time, we never knew how to address this. Our current paradigms are, you try to decrease the energy demand in the heart. Every kind of treatment that we're using, beta blockers, ACE, ARB, hydralazine, nitrates, I heard a lot of stuff. I'm not a cardiologist, but what it does is, it reduces the energy demand on the heart. It does not address the supply issue. It does not address the mitochondrial capacity, the increase in the ROS, or in the ETC. And that's why we have drugs now, and in the next few years, drugs that will come in that actually address the mitochondria. So I spent so much time trying to introduce this new molecule that actually works at the level of the electron transport chain. Remember that the electron transport chain has about 5 complexes. To the complex 1 and 2, fuel is supplied. This pushes hydrogen ion into the membrane, and there are some rate limiting steps. It's coenzyme Q, the cytochrome C. At the end of it, one hydrogen ion comes back and ATP gets converted to ATP. This is the basis of the electron transport chain. Imiglamin is a first-in-class molecule. It has not been there before, and it doesn't have Western powers and Western marketing technology to push it. But it's approved in Japan, which is tougher than the US FDA. It's available in Korea, and now for the last 3 months, it's available in India. What does it do? Because it works on the mitochondria, it improves both insulin production as well as insulin sensitivity. It also reduces hepatic gluconeogenesis, and because it works on mitophagy and autophagy, reduces beta cell apoptosis. Now, how do you look at imiglamin? Can you see this is metformin? If metformin gets a cap on it, it becomes imiglamin. You put a cap on metformin, you get imiglamin, right? But it's even more than that. It actually goes beyond metformin, and there are some multiple differences. How does imiglamin work? I said the respiratory chain is important. 1 second. It works at the respiratory chain. It reduces ROS influx, and it allows fatty acids to be completed. I'll spend 2 minutes on this. Just before we go on, the therapeutic dose is about 1000 milligrams twice daily, a half-life of 13 hours. In renal impairment, it can be used. Reduce the dose to 500 milligrams BID. Not contraindicated in heart failure, not contraindicated in renal failure, not contraindicated in hepatic failure, and I'll actually show you some animal data that shows that it may be beneficial. How does imiglamin work? What it does is, it improves the uptake of the electron chain in this third part. So it sort of bypasses 1 and 2 and takes the hydrogen ion chain directly and improves the third part is where the synthesis of the hydrogen ion chain occurs. All the substrates are coming, hydrogen ion is present, and it's pushed up, right? The second thing it does is, it increases the substrate for NAD to NADH. This important protein is NAPTMP, and it's an enzyme that increases the production of NAD to NADH. That's where imiglamin works. The third thing is, like metformin, metformin does it irreversibly. It inhibits the action in 1, which is where the fatty acid goes. So it sort of reduces the amount of fatty acid dependence into the this thing, and it prevents accumulation of fatty acids. Lastly, and very importantly, what happens in diabetes, what happens in heart failure, what happens in mitochondrial dysfunction is this pore called the PTP. It's a permeability pore gets opened in the mitochondria. When that happens, toxins get released into the system, mitochondria get destroyed, the cells get destroyed. What imigliment does is it prevents the PTP pores from being opened. Therefore, it preserves mitochondrial longevity. Right? So this is what it does. Let me summarize it. Increases C3 activity, increases the amount of NAD, increases potassium and ATP closure, indirectly works on calcium flux, which is very, very important for the heart, increases insulin in the beta cell, and increases calcium and contractility in the heart. It also works in the other spaces, increases insulin sensitivity, increases downstream signaling. What it really does is, it's one of the first in class drugs that works in the bioenergetics of the cell. Metformin is an old agent, it does work on the mitochondria, but here is a 10-time improvement on what metformin does. Right? So I'm just going to show some animal models because we really don't have human studies on many of this. Some of these are ongoing. This is looking at urine models where left ventricular end diastolic diameter and left ventricular shortening with imigliment, right? This is showing in an HFpEF model of mice what happens is prevention of progression of HFpEF and actually improvement in contractility. This is its action on acetylcholine-induced septal relaxation, showing that there is clearly improvement in LV contraction and LV coronary relaxation. This is looking at renal function. This is a murine model, but look at what is happening. There's a reduction in the glomerular injury, reduction in interstitial fibrosis, and if you notice, there's an improvement in albuminuria. We are looking at human studies that are coming, but these look very distant. So to sort of summarize, and remember, I showed you what is the basis, what is happening, what is the current therapy. So what will be the next generation therapies? That includes imigliment. There's an increase in biogenesis, restoration of mitochondrial function, increase in electron chain transport. Future drugs will increase cardiolipin and redox buffering capacity. So I think it's time to start thinking about the next generation therapies today, because yesterday is history, tomorrow is a mystery, but today is a gift. That's why it's called the present. The present, we have a molecule that has potential, that has promise, and it doesn't have the Western backing of big pharma, but I think a lot of Indian companies have taken it up. It's very safe. It is not contraindicated in cardiac failure, not contraindicated in renal failure, and it's time we give it a try. Thank you so much.